Desfazemos neste instante a mesa solene de abertura e iniciaremos a Conferência Magna. Pedimos que permaneçam na mesa o Dr. João Vítola e o Dr. Marcelo Queiroga para presidirem.
Convidamos a doutora Leslee para apresentar a Conferência Magna. Doutora Leslee é uma das cientistas mais reconhecidas no mundo. Ela está no top 1% de todos os investigadores clínicos em número de publicações e amplamente premiada nos Estados Unidos por ter os seus artigos citados mais de 1000 vezes na literatura. Doutora Leslee.
So, Joe, this is a hard act to follow. I'll do my best. Thank you all for staying and for sitting through this. It was quite impressive, all the achievements that you have all accomplished throughout the last few years. I'm going to talk about population risk. And so I'd like to, I have a lot to cover, and I'd like to move along and begin the discussion about population risk. All of you are well aware that there are strategies to control population cardiovascular risk, and it's based on these principles that we see here espoused by the World Health Organization. We have an optimal distribution of health for a population, but we have a core group of the population which is high risk, and the best way to attempt to move this distribution over into an optimal distribution is to targeting the high-risk patient cohorts and intensify care for those patients that need it most, those highest-risk patients. Although I have been asked to talk about imaging, I'd like to introduce to you new concepts about imaging-guided strategies of care. So not just about detection, but how we use imaging procedures to actually initiate pathways of care, to actually target treatments of care, to actually to go beyond what we previously thought was just about diagnosing, but moving beyond that in order to link and optimally care for our patients. So what you have learned in medical school, all of the approaches that you've seen and heard and thought about before in terms of imaging and diagnosis, you have to think totally different about that. An imaging procedure, a diagnostic procedure, the sole goal of that is to guide care, not just detect. So the detection is the first step. There are lots of new novel diagnostic approaches. If you have blinked your eyes over the past 5 years, we've seen tons of approaches, anatomic approaches, functional imaging or stress imaging approaches, as you can see on this slide. I'd like to just share with you one of these approaches because you've probably not seen this. This is looking down a coronary artery. This is taking 5mm slices down a coronary artery. You see all those colors. White, it's calcified plaque. Dark red is a necrotic core, a high-risk plaque feature. We're going down that coronary artery using non-invasive techniques. Fascinating. And we are just on the precipice of doing more and more non-invasively. All of you are very familiar with a lot of these techniques, but I'm going to introduce two concepts to you of how you employ each of these approaches. Let's start with an anatomic approach. And I'm talking about a non-invasive anatomic approach. Of course, it's an anatomy and an anatomic approach. We're going to detect obstructive coronary disease. And what we can do with CT-based techniques is go beyond the detection of obstructive coronary disease. And we can tell you all about plaque in those coronary arteries. And of course, when we know a patient has atherosclerosis, we can be much more intensified with your preventive strategies. Of course, we don't necessarily want to employ these in all our patients, but if we can think about these patients that are at the lower risk part of the continuum, those low to intermediate symptomatic patients, detection and prevention are key to averting an acute coronary syndrome, reducing myocardial infarction, and the sequelae of much more severe coronary disease. So how can we use CT to target prevention? Well, if you've not seen any of these images, here's the spectrum of coronary disease that we can detect with CTA. A normal coronary, minimal disease, more milder disease, moderate disease, and more severe disease. When we test a population, about half the population, despite the fact they're having symptoms, has no coronary disease or no plaque. Just think about that. We can give an answer to a patient, about 1 in 2 patients that they have no coronary disease or any plaque. We can also uniquely identify those with just minimal disease. And you say, well, it's minimal disease, but they have atherosclerosis. This is what's not detected by any other modality, uniquely. So we have an opportunity to identify atherosclerosis and initiate and intensify preventive strategies in these patients particularly, and then to shift this smaller cohort of patients over to much more intensified anti-ischemic secondary prevention, potentially ischemia-guided management in this patient population. Let's look at some of the unique data with coronary CTA. Here we see 2 cohorts, one undergoing stress testing, one undergoing CTA. Normal, no coronary disease, no plaque, non-obstructive plaque, single vessel disease, and multi-vessel disease. Nice ability to risk stratify. Here's a functional testing approach. Normal, a mildly abnormal, moderately abnormal, and severely abnormal. Do you find something unique about these event curves? Well, we see there's not a clear differentiation on the stress testing side between normal and mildly abnormal studies. A failure to provoke ischemia does not exclude risk. That's an important message. Within this group of patients are patients without any coronary disease, no stenosis or plaque, but it's also those patients who have atherosclerosis, but not ischemia-producing atherosclerosis. So they can't, in this cohort, using functional testing or stress testing, you'll never be able to delineate the risk as well as you can by understanding the patient who has no coronary disease, no stenosis or no plaque, and then clearly differentiating a slightly elevated risk when you have non-obstructive disease. This is clearly an advantage for coronary CTA. Now we have what's called a lot of high-risk plaque features, positive remodeling, that expansive remodeling. You have this napkin ring sign, which is a sign of thin cap fibroatheroma or low attenuation plaque, or this very dense plaque, spotty calcification. All of these 4 features have been associated as precursors to an acute coronary syndrome and to major coronary disease events. These we can visualize very well on CTA. And what's interesting, there's been a lot of papers showing how well these markers risk stratify. But what's fascinating for all of you clinicians in the room is that these risk markers uniquely predict risk in patients with non-obstructive disease in women, especially younger women. That is such a unique population that's so hard to risk stratify. And in the young in general, these markers can be very predictive, especially as strong precursors for acute coronary syndromes. Now let's look for a minute at the clinical trials. Scott-Hart trial, which was published, the first part of the Scott-Hart trial was published in 2015. Over 4,000 patients, largely those with symptoms. They had a high rate of obstructive coronary disease, randomized to CTA versus standard of care. The initial primary trial results had a trend in terms of improvement in coronary disease death or myocardial infarction, but a non-significant trend. They had a planned secondary analysis, which was just published last August in New England Journal of Medicine, showing a roughly 40% relative risk reduction in reducing coronary heart disease, death, or myocardial infarction with CTA-guided strategies as compared to standard of care. Now, the authors posited that CTA was much more effective at guiding preventive care, and they have shown higher use of antiplatelet therapies, statin therapies, et cetera. This has been validated in other trials as well, so it's not a unique finding. Of course, we can say that we'd love to see several other trials which elicit this same benefit, particularly those in countries like Brazil, countries like United States, when this was obviously in Scotland in a different type of population. But it's important to realize that what the protocol dictated was when there was non-obstructive disease, evidence of plaque or obstructive disease, the attending clinician or primary care physician was prompted by the trial coordinating center to prescribe preventive therapies. So even though this was a pragmatic trial, there was still some form of protocolized care which could have contributed to this marked reduction and improvement in outcome in patients who underwent an initial or a prompt CTA-guided strategy. And of course, this is part of the reason that the United Kingdom's National Institute for Health and Care Excellence recommends coronary CT angiography as a preferred initial diagnostic test. To recap, you have an improved detection of coronary disease and coronary disease risk. You have novel visualization of atherosclerosis, even when it's not obstructive. And in patients with no coronary disease or no plaque have very low risk. And of course, this is why the NICE guidance document estimated significant cost savings because of this improved detection and better guidance to therapeutic strategies, roughly speaking around £16 million per year for the UK alone. But let's think about higher risk patients. Now we're shifting away from that lower risk de novo chest pain population. We're shifting over to looking at detection of ischemia, those patients that have stable coronary disease or at high risk of having ischemia in this cohort right here. So we're shifting from a targeted preventive strategies to a combined preventive and anti-ischemic therapeutic strategy. But why shift? What is the importance of ischemia-guided management? Well, stress test findings, heart rate, ECG changes, SC segment depression, arrhythmias, all of these factors, the knowledge of any given ischemic threshold, these formulate our guidance for referral of patients to cardiac rehabilitation, exercise prescription, and guide the utilization and intensification of anti-ischemic therapies. Depending on the severity of ischemia, this evaluation may also include invasive coronary angiography and coronary revascularization. Now, of course, many of you in the room know that the trials that we have heretofore in stable coronary disease, they had requirements for patients to have ischemia, but not necessarily strict criteria. So, for example, in the COURAGE trial, roughly 60% of patients had so little ischemia that many of us would characterize it as not being prognostically significant. So we didn't do a lot of service to our patients in terms of producing positive trials. And the result was 2 negative trials, and roughly speaking, about $125 million spent on both of these trials. What we did understand is that coronary revascularization procedures, in this case in the COURAGE trial, percutaneous coronary intervention plus optimal medical therapy resulted in a prompt and sustained improvement and a reduction in anginas for these patients randomized to this cohort. Optimal medical therapy, as you know, requires titration, evaluation, and it's much more hands-on with patients who could have persistent symptoms throughout the course following the randomization, and that's what we saw in the COURAGE trial. We saw that it took longer to get patients to be angina-free. So this is a distinct advantage to coronary vascularization. We haven't been able to observe in a stable population an improvement in reduction in mortality, with exception to those patients with significant left main or left main equivalent disease. But in generally the population with stable coronary disease, the greatest benefit is in patients in improving angina in those patients. Now we also, in addition to improving angina, we have been able to observe with those patients randomized to percutaneous coronary intervention plus medical therapy, a marked reduction in ischemia. So two big pieces of the puzzle in caring for these patients: reduction in angina and a reduction in an improvement in ischemia, or a reduction in ischemic burden. Now there's other ways to look at ischemia. In this case, it's lesion-specific ischemia with invasive fractional flow reserve. A series of trials like the FAME trial showed that an FFR-guided percutaneous coronary intervention approach resulted in 28% fewer events as compared to using PCI in all anatomically suitable lesions. So looking for ischemia to guide intervention is a critical component of understanding revascularization strategies. And as well, most recently, the MR-INFORM trial, which was published, I think, within the last 4 to 6 weeks in New England Journal of Medicine, now actually compared two strategies. Again, an FFR-informed strategy, but the second strategy was a magnetic resonance imaging strategy using stress perfusion imaging. Now, this was a non-inferiority trial, so the fact that you couldn't differentiate these two curves, it was the point of the trial. So the results of this trial revealed that MR perfusion imaging was not inferior. If there aren't any statisticians in the room, I can say that it actually resulted in similar outcomes to an invasive approach. So this now takes our ischemia-guided approach and it moves it also into the non-invasive world, where we now have another piece of the puzzle on using non-invasive imaging or non-invasive ischemia as well to guide the use of percutaneous coronary intervention with MR-informed results. Many people in the room have participated in the ischemia trial. This is taking all of the courage in the Berry 2D now to a whole other level to look at patients with moderate to severe ischemia, a blinded CT angiogram, randomization to an invasive approach versus a conservative approach. The primary aim, and this is how you understand the ischemia, is an initial invasive strategy of revascularization and optimal medical therapy superior. Now that's important, we're not looking for equivalence or non-inferior. Is it superior to a conservative strategy of OMT alone? Now what's interesting, and I want you to think about this, is the conservative strategy means deferral of cath, and that cath would be reserved for patients who fail optimal medical therapy. That first stop along the care of these patients is to optimize medical therapy and to treat them as if they have obstructive coronary disease. We'll see these results at the American Heart Association. Those trial investigators, I know I've talked to a number of you in the room here today. We'll see you at the AHA when this is presented as a late-breaking clinical trial. I was actually one of the 4 PIs of the ischemia trial that led the stress imaging portion of that. So it's been 8 years of my life. So it is clearly a time for a change in our diagnostic evaluation. I think NICE got it right, if I can say it that way. Think about unfolding these strategies, different approaches to target prevention of those patients with atherosclerosis and much more intensified care, ischemia-guided care in those patients who are high risk and those patients who have known coronary disease. What we see is a ton of clinical trial evidence. Early detection of atherosclerosis is key to guiding prevention to improve outcomes in patients. Ischemia-guided management is key to actually particularly improving anginal symptoms, reducing ischemia, reducing acute coronary syndromes. Our new paradigm is to no longer think of non-invasive imaging as a means to detect something. It is the goal of a diagnostic procedure to direct care. And now we must realize that treatment strategies based upon non-invasive imaging are truly crucial for us to improve our population health. Thank you very much.